supposed to be, today we're going to talk about a couple of things people learned at the SGIM conference in Denver. It's supposed to be open, so if you have any thoughts, you want to jump in when someone's talking, feel free. So just for us to sort of share things we learned about, since obviously everyone couldn't be at everything and some people aren't here. So just going forward for May, this is the sort of grand round schedule we have coming up for May. Obviously our faculty meeting, and then we have some three clinical talks and a research talk for the month of May. So this is the department at SGIM with their posters. Everyone had a good time. We all learned a lot, and we had some fun too. Everyone had dinner, so it was a nice time. So, all right. So I think Claire's going to start us off talking about something she learned about this. This is not. There you go.
Press the right?
Yeah.
Okay. I think I was the only one at the workshop, so whatever I say goes. But I went to a workshop on teaching transgender care to general internists, and I went to the workshop because, in all honesty, I don't know anything about this, and I felt like we have a big transgender institution here at Mount Sinai, and so I felt like I needed to learn some of the basics. So the workshop was led by a group at the VA in Minneapolis, and they started a program through the VA that does e-consults to all VAs and VA satellite clinics throughout the country. So there's 3 satellite places, Minneapolis, LA, and then there's somewhere else that's coming up, and Tucson, Arizona. And through a directive in 2013, the VA facilities they provide transgender-related care to vets. So this is how that program started, to meet those needs. And so the slides are adapted from them with permission, but the learning objectives really weren't to provide like comprehensive knowledge of how to do transgender care, but to describe basic principles of transgender care related to primary care, to identify challenges and to recognize some unstated provider concerns. So they started with this study about VA docs, family docs, and it was a survey on their readiness for treating patients with transgender dysphoria. And so the first part just says that 75% of doctors felt like they were able to provide non-judgmental care to an individual with gender dysphoria. 87% though felt like they did not receive sufficient education on how to provide cross-hormone therapy. And then interestingly, when asked if they would prescribe cross-hormone therapy for eligible patients, about 50% said no. And you can see that really on the bottom here, 19% was because of lack of comfort, and there's some ethical concerns. So there's clearly some education that needs to be done and implicit bias, even among physicians. Okay, so this is their team. The purpose is to guide providers at the VA. There's these 3 hubs in Minneapolis, California, and Tucson. The group consisted of 2 MDs, which are general internists, an NP, a psychologist, pharmacist, social worker. And most of their e-consult topics since 2013, about half have been questions on providing hormone therapy for patients. So the general principles of care for transgender primary care are having a clear diagnosis of gender dysphoria, providing cross-sectional therapy, surgery for those who are interested in surgery, and then general screening for preventative care. And then just to go over some definitions, because I think they're kind of loosely used, but so birth sex is your assigned sex based on genitals when you're born. Gender are traits that society associates with sex. Gender identity is your sense of self. Gender expression is the outward appearance of that sense of self.
Oops, sorry, just getting separated.
And then transgender is when your gender identity and or expression differs from the sex that's assigned at birth. And then gender identity, having gender identity disorder doesn't always develop into gender dysphoria. And dysphoria is really when there's what we would say pathology, or when you would have this diagnosis. And the DSM-5 changed their definition in 2013 from gender identity disorder to gender dysphoria to try to destigmatize the definition. So to meet the criteria, it's greater than 6 months of marked incongruence between your experience or expressed gender and your assigned gender. You have to meet greater than 2 out of 6 features, which are all consistent with that. So marked incongruence, a strong desire to be rid of one's primary or secondary sex characteristics, strong desire for primary or secondary sex characteristics of the other gender, a strong desire to be the other gender, and a strong conviction that one has the typical feelings and reactions of the other gender.
Interesting, this characterized as a disorder.
I think they were, I think they're trying to move from disorder to dysphoria.
Because it's like, whatever. It's a classification, the actions of an abnormal, whatever. I don't know.
I think they now only use it to treat it. Yeah, to treat it. Like you have to meet that criteria to be eligible for hormone therapy and for surgery.
It's interesting that it's considered among a pathology of,
Something's wrong. Yeah.
Because I don't think it's an access for normal, mental stuff,
Gender?
Normal, whatever, or any other thing that we all have, whatever.
People can actually change their birth sex. That's not true of every state, but that's what we said in a piece of legislation. And I think EPIC is also doing a lot of language in order to make it more gender neutral about the application, because there's a lot of issues with transgender patients being identified with the wrong sex and the wrong pronouns and like that.
And it's really hard to change. I feel like it's really hard to
It's
change
really
that.
challenging, so EPIC has been working trying to make that more gender neutral.
Yeah, I don't know what you do if you have a patient. How you get it changed in that.
It's very hard, and we do a lot of training around this with the medical students. And in fact, every medical student now is trained to ask a patient what their preferred pronouns are and what was their birth sex and what gender do they identify with. So it's really interesting to see how this is impacting medical education.
I had a patient who had, like it said, had a whole chart that said, she had a whole chart that said male, and when I saw her, she basically just made a new chart essentially, and had to match it for two charts, and that's what it still worked out. No, I don't think that's the best
should
way.
be
to do
easier.
it.
It's easy, it's the only way that we
So just importantly to recognize that not everyone who's transgender has gender dysphoria or discomfort. So they use a lot of the principles from this World Professional Association for Transgender Health. You can download the free book online for standards of care for patients with who are transgender. And really the goal is really individualized. So lasting personal comfort with gendered self to maximize psychological well-being and self-fulfillment. And really the overarching kind of theme of the talk was that's really individualized to each patient. So some patients might not want hormones, some patients might not want surgery, and it's really eliciting the patient's goals and readiness to make those changes if that's in line with what they want to do. And that book has a lot of easy information. It's like 100 pages, and you can download it online. So the 3 main key components, depending on the patient's goals, for psychological therapy, if they're struggling with where they are and kind of the readiness to change, if they're interested, addressing any underlying mental health, cross-sex hormone therapy, if that's something that's in line with their goals, and then sex reassignment surgery, which not everybody wants, and it's harder to get covered. So really the basic principles of hormone therapy are pretty easy, although it seems like a little bit daunting to think about, but provide concordant hormones and suppress the discordant hormones. And monitoring is really to watch out for toxic levels. You're kind of shooting for, the goal is for a clinical goal. So like how they're feeling, it's not necessarily at one level you're looking for. You're just checking to make sure you're not giving them toxic levels. So basic principles for feminizing hormones are estrogen plus an anti-androgen. So some of the most common ones used are finasteride, Lupron, flutamide. There's a bunch of different options. masculinizing is testosterone. And you just need the testosterone because that suppresses all the estrogen effects. So just some important contraindications. So there's really only a couple of true contraindications, and then a lot are about concerns and monitoring. So estrogen, any history of VTE, testosterone, history of recent cardiac disease, and then for both hormone responsive tumors. And then a lot of concerns which they address, which have been brought up as the relative contraindications, but people have been denied care based on them. So just consider if the patient is interested in future fertility, to have that discussion about hormones will affect their future fertility, and then smoking with for patients who are going to get estrogen. And then they went through the timelines of feminizing hormones and masculizing, and I think the big take home was that to counsel patients that it takes time. So these changes don't happen right away when you start hormone therapy, and it doesn't mean that they're not working. So some outward things that patients will be looking for. So feminizing, developing breasts. It starts at about 3 to 6 months of taking hormones, but it takes 2 to 3 years of hormone therapy to see maximal development. So it doesn't mean that they're not getting enough hormones, it just takes a long time. And in the same regard, if somebody starts hormone therapy and they want to stop, there's time to stop and you're not going to see these effects right away. And then really some same kind of timeline for masculinizing hormones. So gender affirming or sex reassignment surgery really, again, is highly individualized. A lot of patients don't want surgery or would consider it later on in their course, and it's important, again, to elicit what their goals might be. And then just something to think about if they do undergo gonectomy, it can affect hormone levels and then would affect how much you need to give them. And again, not all patients want or need surgery. And then preventative care, in a very simplistic way, moving forward is really you treat them like any other patient, and you screen for organs that are present, and you don't screen for organs that aren't present. Which is a simple way to think about it, but not something I necessarily thought about. And then just something important to highlight, that screening may help or hurt their sense of gender. So if you're talking to a male to female patient about prostate cancer screening, because they still have prostate, just to consider that that could bring up a lot of kind of feelings that they have about their gender disorder. And then these were the references they used. Again, that wpath.org has a lot of good information.
The country with the largest number of gender exchange surgeries, is Iran. Because like in the 70s, there was this very passionate transgender that Dr. Khomeini, and really convinced him that that it was like something that you cannot, like it's something that you cannot really change, and because the Quran doesn't say anything, because homosexuality is forbidden in Iran. Right. Actually, you can give a death penalty for homosexuality. And he convinced him that and because it's not in the Quran, Khomeini issued a fatwa that transgender is okay. And then, so anybody that's an homosexual that is caught, he has a chance of either doing surgery or, and so actually they have this whole documentary about it. It's like the largest number of surgeries in the world. It's just strange.
So here we have a pretty robust transgender center. So I'm sure some people are aware, some not, but you can refer patients here. They don't necessarily have to do all the primary care for the patient. If you want to stay involved in doing primary care, but they can assist with hormone therapy or get into surgery. So sort of like moving outside transgender center, all they're more than happy to take patients.
Curious, do you know what's
I think it's in the icon.
That's here?
There's also
Oh, I figured it out.
there's also a large group down in that.
Oh, I'm sorry, you're right. It is down.
They also have a partnership with County Board, which is another practice that helps a lot of teenagers who are immigrant LGBTQI. There was a really interesting article in the Times about a woman who identifies as lesbian and her partner who is a transgender woman and how they have we're going through to reverse her transgender partner's hormones and try to kind of I have a question. You had brought up the medical education here, how people are trained to ask what a patient identifies as in terms of like pronouns and stuff. I was wondering how that, like, has that been tried in like a real setting? Like, I just wanted to know if it was well received.
Yeah, in general it is. I mean, I know that we get a lot of coaching from Barbara. Oh, I know the woman in VI. She gets a resident.
Barbara Warren.
Yeah, Barbara Warren. And Zoe Goldstein, who's a nurse practitioner, and there's a whole bunch of videos about, dealing with a sensitive approach to someone who's transgender who maybe still has breast and needs a breast exam or mammogram or still has cervix and some pap smear. But what the medical students are taught is they say, I identify, I'm going to ask you some questions. I just want to know what sex was assigned to you at birth, what gender do you identify with. I use pronouns, she, her, what pronouns do you prefer me to use, and how do I need to address you?
Can I say that to every patient?
And, like they say to me, do you do this with your patients? I'm like, well, I've been dealing with this 85-year-old woman for 20 years, so not so much. But in new patients, I'm trying because I feel like that's sort of the way of the future. But we do a lot around it. We even have a big panel where this year we had 3 women of transgender experience come and address and panel discuss their experiences with the healthcare system for the second year medical students, and they were able to ask questions, and it's really powerful. But there's a lot of work around it right now. I would say in our small groups in the second year of AFM, we probably have about 4 sessions at least related to transgender health.
And Shannon's been sharing with us stuff on osteoporosis.
Well, I have a few topics I can talk to you guys about. I thought the hormone replacement lecture was very interesting. I did go to osteoporosis, and I personally didn't learn much, but if you might know about that. Or I'm not going to use slides, so we'll just kind of talk it out like I do in GYN clinic. So do you guys know what symptoms we use combined hormone replacement therapy in perimenopause or menopause? Like, in what situation you would consider giving the patient this? Yeah. So what if they ask about osteoporosis or cardiovascular risk or any of those things?
15 years ago, we would have given it. Now we don't.
Yeah, so what I liked about this lecture was that it really went over the Women's Health Initiative. So do most of us in here know what that is? Do we want to review? So basically, it was a study, a randomized, double-blinded study where there was a placebo arm, and what they were doing was giving patients combined hormone replacement therapy with both progesterone and estrogen if they had the presence of a uterus. And if they didn't have a uterus, they could do estrogen alone. And what they were looking at were outcomes in these women to see if it improved vasomotor symptoms, but also if it increased risk of cardiovascular disease, improved osteoporotic disease, increased cancer risks. So what was interesting about it is they went over this timing hypothesis that with the Women's Health Initiative, the age range was very wide. So it was women anywhere from the age of 40 to 79. And a lot of the poor data that was scaring people away from prescribing the hormones was found in that older arm of patients who maybe shouldn't have been started on hormone replacement to begin with. But in this group, which was mainly like PID-trained endocrinologists and gynecologists, they were saying that if you start in women that have good cardiovascular health, have clean coronaries, that you can actually improve their vascular disease, but not to a point where there were like significant outcomes. So essentially,
hormones don't hurt people, but we're not necessarily giving them a mortality benefit. And so that we shouldn't shy away from them if someone has poor quality of life from vasomotor symptoms, because most patients saw between an 80 and 100% reduction in their vasomotor symptoms on the hormone replacement therapy. So they said, important things to do is to think about starting it within 10 years of menopausal symptoms. Again, that the hormones won't make you live longer, and that your primary outcome is to titrate to vasomotor symptoms and not end organ outcomes. So what was interesting is that topical estrogen has a higher absorption rate than actually the pill, the tablets that you place. So for like vaginal atrophy and things like that, if you want to think about just using the tabs, and I wrote down some names. If anyone's ever around Wednesday morning, I always have my notes for this stuff in gyne clinic. But I thought that was interesting. Additionally, there's a difference in when you need to think about ceasing hormone replacement therapy in women on combined therapy. It's 5 years. If they don't have a uterus and it's estrogen alone, you can use it up to 15 years, which I thought was amazing, before you have to have the risk-benefit discussion about it increasing mortality. And actually, it was the progesterone arm in the combined therapy with breast cancer risk that they were looking at after that 5-year mark. So what they like to remind their patients about is their general risk remains the same. So if they get breast cancer, it's not necessarily because they were on this therapy, but to review like average risk of breast cancer, and then review what that risk will then be if they continue therapy, which I would have to go back in the slides and look at notes. Another salient point I took from it, they did some questions, and one of them was about a 48-year-old woman who had a history of RA, and she was having bad vasomotor symptoms, and she had been postmenopausal for about 13 months, and they wanted to know if you thought systemic hormones were okay, since we think about the contraindications to using hormones. So what are some of those, like Claire was mentioning? Yeah, so cardiovascular, like existing cardiovascular disease, clots, history of coagulopathy. So actually they said anything that is a risk factor for then getting cardiovascular disease is not a hard stop, that they have to have existing cardiovascular disease. So in your RA patient who has good cardiovascular health, you can use it. So then my question was, well, how do you know if you haven't? So I said, would you do like a coronary calcium score on her? And then they said that's the road you would likely have to do. You'd have to risk stratify them. It would be a very individualized decision. So I thought that was interesting.
Because this is their elevated risk based.
Because they're in this like pro-inflammatory state. So you want to really know. You probably want to know like their ASCVD. You want to know what their coronaries look like. Like it'd have to be a very.
Yes, for us, like most of like our sort of perimenopausal patients, like most of them here have like some risk factor, like strong risk factor.
But what's interesting. Bit of a Dr. Edelman panel, and I have these very normal walkie-talkie patients that are like, I'm interested in this, and I was like just a deer in headlights with, no, we don't give it to anybody, but like, what I learned is that 1 or 2 of my patients, could potentially use it and benefit from it. Trying to think what other points they took away from this. Did anyone have any specific questions about it? Oh, another thing they said was to try to use micronized progesterone with the estrogen, because it had a lower risk of increasing cardiovascular disease as well as the breast cancer risk. You can also use the Mirena, but that's not FDA approved. So I thought that was interesting. Another thing to think about with the progesterone is cyclic versus constant dosing. So if a woman's still perimenopausal and having periods, you would want to use cyclic dosing so that she's not, like you would try to time it with the current periods. But that's something you have to discuss with the patient, because again, when you take off the progesterone, endometrial shedding. Oh, and this was also interesting. So topical estrogen does not increase risk in the presence of previous cervical cancer, which I have to look into, but she said if you think about it very logically, there's no estrogen component to most cervical cancers, and they felt comfortable giving those patients topicals or the intravaginal tabs for local symptoms. But then there was a new report that came out that lubrication is just as good as topical estrogen, so I've been going back to telling patients to try to use that, although I don't know if we can get So that's the other. As always, like I teach my kids in clinic, you know, the transdermals have lower clot risk than the orals just because of metabolism. So think about that, and you know, ask your patients just about vaginal atrophy and all those things, because it really affects quality of life. And a lot of these women, usually like their persistent urinary symptoms are just from atrophy or you know, symptoms of increased pH in the vaginal mucosa and loss of integrity. So, anyone have any questions?
Those are just expensive.
Yes, and you know what's interesting? I go to the geriatrics lecture, and I was hearing how Medicare likes to stop covering it at 60. So that was like a talking point that a lot of these physicians had upset patients that they just wanted to stop covering it. And then people were asking, I guess, about bioidentical hormones, and of course, the doctors were like, we really don't have much to say about that. So those are just like custom compounded, you know, forms of endogenous hormones that I guess a lot of these doctors have to deal with. And they were like always try to defer to the ones that we understand, you know, dosing patterns rather than going with that. Yeah, just basically like Kenny was bringing up, doing like a really thorough past medical history review to make sure there were no cancers that you're, you know, ER positive or family history that might be concerning. I asked about BRCA patients post mastectomy and oophorectomy, and they said that definitely they should receive hormone replacement therapy until they become an appropriate age for menopause, because the risk of dementia and osteoporosis outweighs any risk they would obtain from getting the hormones and having like cancer occur from that. So I think like there's just a lot of patients we get here that have these random procedures in other countries, and the poor things go into menopause in their 30s, and we catch them at like a random time, and a lot of them have escalation of disease that maybe shouldn't have been as severe as it is just because of that lack of hormone exposure for that period of their life.
That's interesting though. I would have thought, like, not thinking about that, that's a person that should not get, you know, estrogen replacements. That's important to think about the recovery when you're treating some people.
I think we're definitely undertreating a lot of people, and most of the time those patients don't complain about that stuff. So, yeah, I thought it was an interesting lecture. Have I been able to do? I have one patient I'm doing this with, and it was pre this lecture, so I'm gonna go revisit her chart. I do know I have her on progesterone and estrogen, so that was, you know, again one big point. You don't want to increase endometrial cancer risk by not giving progesterone to oppose endometrial hyperplasia. But these women are brilliant, and I have their contacts if you guys have questions about their lecture. But I thought they were very informative, and the slides are on the SGIM website. So if anyone wants a copy, I can also share those.
Family history relative? Like family history?
Yeah, I think it's relative. They didn't say they really meant just like hard stops in the history. They felt very passionate about giving people their hormones. Yeah. You know, the other thing from the osteoporosis lecture, and again, it might just me being a newbie attending, but zoledronic acid, you know, is a once-a-year infusion, and they were saying it's silly we don't give it to patients that come into the hospital with hip fracture, because again, they only need it once a year. As we know, with like the bisphosphonates, you get a lot of piloesophagitis or non-compliance just from the dosing of the medicine. So we could be thinking about sending our patients, you know, for infusions once a year. It's a cheap medicine. That there was no improvement with like the anabolic osteoporotic medicine. So these much fancier, you know, hormone-related medications do not need to be put in front of the bisphosphonates. So really trying to get our patients to take the bisphosphonates, and just that we're doing a bad job of treating osteoporosis. Like there was one physician in there, she's like, I don't like the medicine, so I don't treat it. And they're like, but this is a huge epidemic. And in GYN clinic, we've actually tried to get the students comfortable with the residents, like teaching them how to calculate the fracts, having them follow up appropriately, making sure the patients are taking the medicines, understanding the importance of them.
What is it? Because a couple of years ago, I was having patients do her Proline injections at home. And when the endocrine people said, like, you're absolutely not supposed to do that. It's supposed to be like
monitored
or administered
site.
Because they were getting a flu, they were saying they can sometimes have severe
Yeah.
reactions.
Because the lady she was doing fine, and then I sort of felt guilty that I was breaking.
They only said it's because sometimes people have a bad reaction. Then the other interesting point was that with the atypical fractures with bisphosphonates, they said very, very low risk, but you have to image that with a CT. X-ray will not pick that up. And if a patient's complaining about like deep aching pain, that's when you should suspect the fracture.
It's usually anterior.
Yeah, like the femur.
Because that's usually ahead of time.
Yeah, so they're like, if you have a patient on bisphosphonates, be aware of that. Obviously, women with like metastatic breast cancer, osteonecrosis of the jaw, so be aware of that. But it was really the atypical, because again, most of the people in the room were like the side effects, like if someone gets them, can be pretty severe. And they said, you know, if you're just like being careful and watching out for the warning signs, and most patients never deal with it. And the improvement that we see just in their stabilization of their bone mineral density is pretty impressive.
Okay, so I have one other topic I can talk about. So for those who were there, sorry, back to pictures. Pictures of everybody. Yeah, no margaritas.
No website.
Those aren't reimbursed, so they can't be. Yeah, they can't be in the picture. So this one topic I thought sort of like an interesting moment from the conference. So the plenary session Friday was sort of all about technology and medicine. That was sort of like the theme of the conference also. So they had someone speaking who works with IBM and Watson. And it was, I mean, it was really interesting. They do really like fascinating things. And the sort of the point this person had was that all this technology and these predictive models, like can the computer, diagnose, difficult to diagnose conditions or take all the patient's symptoms and data and give a diagnosis that's sort of better than the physician or equivalent to the physician. So the person's point was not that the point of like these systems is not to replace the physician, but to sort of supplement the physician's knowledge with those extra missing pieces to sort of together try to come up with these diagnoses. That sounds like great, and over time, I think this is going to like become more and more easier to like wrap our minds around and utilize on a day-to-day basis. But the majority of the audience here is like general internal medicine physicians and primary care providers, and so how does this stuff like relate to our lives? So so like for example, they showed that like Watson can 90% of the time be concordant with tumor board recommendations for for oncologic management, which is scary to the physician, but again, it's about sort of supplementing the knowledge we have in our abilities with that extra 10%. So that was the guy's point. And in many ways, like technology for a lot of, especially on oncology and some of the subspecialties, has been they're really like novel ways to utilize that technology to better help the patient. So, for example, like Joe Biden and under the Obama administration, they kind of started this whole initiative to basically like join the siloed centers for treatment of various malignancies. So you have all these like really smart people working all over the country and all over the world with hundreds of new drugs, immunomodulators, checkpoint inhibitors, and working in silos and trying to recruit patients for clinical trials based on a patient's molecular profile, but like within an institution or a group of institutions. So the Biden Cancer Initiative, which sort of came out of an initiative started under the Obama administration, was to the point of which basically to link everyone together and to be able to sort of recruit patients not just within a group of institutions, but from different countries, and to try to match the patient's molecular profile with clinical trials going on elsewhere, so they can get potentially a drug that might work well for them. So that's great. It's like obviously like an awesome use of technology. And then they were saying that Watson is sort of can also help like value-based care and help like providers and healthcare systems, deliver care more appropriately. So that sort of like got some people thinking in the primary sort of like care, where like, is this really like, how applicable is this to us? And so at the end, like one gentleman stood up and sort of were you there for yeah. And it was like really like I don't know, it's really like interesting moment. It was really funny. He sort of like gave like a challenge back, so I'll get to that in a second. So we have sort of this, and there's lots of like other technology. We have like a million different apps, and there's all these apps for like diabetes and meditation, and that's all just blood pressure down there that we can like recommend to our patients and help track their conditions. But like, how does that really like help us, and like does that help us like manage the patient? So the audience members stood up, and this is sort of like the gist of what he said. Basically, like there's like so much innovation, technology, like you said, really like important, cool applications like with the sort of Cancer Initiative that are really making a difference. But in terms of like us as primary care physicians, like this doesn't seem like, at least for most practices, doesn't seem like a lot of that like money and effort is being used to like sort of improve our flow on like a day-to-day basis. And that's for many reasons. There's obstacles with EMR, obstacles with insurers, but so we can recommend all these apps and get all this data, but it sort of comes to us sort of separate from like our day-to-day work and not so far like well integrated in our day-to-day work. So obviously this is like a massive topic, but I just get like, and this is not a trick question. Like, do you sort of like agree, disagree with this statement, or like how does this affect your flow and time? But it's not a trick question to just say like, no, this is like all horrible. But I'm just like genuinely curious: has anyone found ways to sort of using like a specific apps or anything that's actually been helpful to them in day-to-day practice? And have thoughts on it?
So if they have an iPhone, I have them use the heart just to keep track of their steps. So I'm very into having my patients try to like use their pedometer and set goals for them, especially in my patients that are inactive.
But do you integrate it into your, like, you spend time when you're in a visit, like looking at their numbers and going over the numbers?
Yeah, no, I'll make them pull out their phone if I say, do you have it on you, or did you? Because if they gain weight, I'm like, did you move?
Right.
Something that people have iPhones and like, oh, I walk like 20
Yeah, so
miles.
like,
The pedometer, like, what's something like, oh no, I did this week. Well, next
no,
time.
it's good because one, they like don't even know it's there, and two, because whenever they know that you could be accountable for what they're doing, it puts a lot more pressure, and that's when I've seen changes in my patients, like when I set realistic goals for them.
So that's
Essentially, talking about like making games out of everything. Right?
Yeah.
And stuff.
Like that Pokemon thing.
Yeah.
People
I feel like I find that like the pedometer apps helpful. I use them a lot.
Yeah, I guess that's pretty simple. That's sort of like a simple to see like track cost out. Doesn't take like a lot of other time.
Did you know that?
But it's funny,
We can go over.
remember that study where like people didn't get more weight when they used their Fitbit, so that thing was actually sort of like, so I mean, I think people like will do it for a while, but they kind of get tired of it.
Right.
Like, they're
It's like a
like,
novel.
it's a thing that it's passive.
Yeah.
Yeah, that's been studied, the abandonment rate of all of these apps is enormous.
That's passive.
But I guess the point is that if you make it this just separate entity and not some integrated part of their routine, like so to his point, yeah, the app itself is not improving outcomes, but at least allowing people to realize that they can like track how sedentary they're being. So hopefully that makes them a little bit more cognizant of that type of stuff.
What do you do, some of our patients will send me their blood pressures, but like, sometimes it's like, it's overwhelming, it's like 40 blood pressure, you're like, I'm gonna need it 40 times a day, things like that. But time do you spend on that?
I use it like in a kindergarten class when they bring in a good assignment. I'm like, this is a great job. And I put it down. I go to like the next thing.
But you have people, because I have some people that like send to me their my chart, like they attach it to their my chart, and you get that like once a week, and then I'm like, okay, I can do that.
And you don't need to send it.
Yeah.
You want to do it.
What about Livongo?
So the nice thing with Livongo is that right now, if it's really abnormal, it goes to the nurse practitioner. So like, I mean, you can do it, but I sort of rely on the NPs to get the scary calls. But you can look at it in the visit, so we'll look at it. But like, you don't
Do
have
you
to.
think the whole program, the whole thing helps?
I think yeah, I mean, it's been helpful because at least they do reach out to they'll reach out like, oh, like, your patient's got like 400 and you can't reach her, and I'm like, okay, she's deaf, she's that sort of thing. So I mean, That's helped.
It's more real time, like they call it,
But
oh,
it's not that it's us, like I wouldn't wanna get that
No,
phone
me
phone
either.
call, but it's nice that
somebody's
it's-
reaching out to them.
Yeah, and then they can, after, they can reach you in daytime hours and do it that way. Cause I don't wanna get the 4 a.m. phone call.
Patients love my chart.
Right.
Yeah.
It's like life changing for someone.
Even my chart's like pretty. No, I agree. People love that, but it's like sort of like limited in what it can do in a way. I mean, it is integrated, which is nice. But like, if you upload anything to it, it doesn't like go into the chart. It's still like in this like.
But I guess
You
just
can, but if we are.
Well, it's in this like
Yeah.
media section, right?
Yeah.
It doesn't like.
No, but
Oh,
like,
okay.
you can send them like real surveys and you can have them upload their blood pressures,
Right.
but we haven't been able
Got
to yet.
and maybe this is something I'm making up, but I do believe it decreases them coming to clinic and using. Like I have high users that now just because they're able to get in touch with me whenever will not run to the ER, will not go to urgent care.
For the last.
Yeah, they'll ask first, so I think that's
Yeah. Right.
exactly. So I do really like it for that.
For that
But I
subpopulation,
feel
other
like
people.
it is the epitome of this double-edged sword, right? In some ways, with some patients who use it, I'm gonna go this way, I'm gonna say they use it appropriately, I can send them their lab values and have a very simple conversation or discussion of this, and this, that, and we can talk more another time. And other patients overuse, and my OB said to me at one point, because they're on it too, she's like, I feel like now it's like email, so patients, they get a thought in their head and because it's so easy, they'll just send it off without thinking, do I really need to ask my doctor? And so there is a lot of extra chatter too, or patients who have a tendency to maybe overstep have one more point of access, and it creates a lot of extra work that we're not given time to do today.
So like those, there was one guy that was like a big overuser, I finally just set limits, I said.
Yeah.
"Listen,
So you
I
just
said,
have to
I'm
set
gonna just talk to you like
boundaries.
once a week. You can
Yeah.
talk to me every day, but I don't have, I said like, I got, 400 other patients. I love that you use it, but like, I'm not gonna answer your other question. You slow down.
Yeah, or if
Yeah.
it's not urgent, just wait 2 days
Yeah,
to
that's what I do
reply.
too.
Because that's what I do. If it's
Right.
not urgent, I don't give them
Never
that
answer
same.
on the weekend,
Exactly.
right,
Or
on the weekend.
yeah,
Exactly.
so only if and it, like Eva said, it has helped a lot. They will slow down.
The one patient emailed because she touched something dirty in the sun.
Lori's
Really?
going to
Oh my
touch
God.
something
It was
dirty.
I
I never touch something clean.
Like, that's what you're sending a message about.
It's hard because I think it's very careful. I feel like I always try to make my response shorter than theirs.
Yeah.
Like, it's like shrink down, and by the end it's like single word.
Yes.
Great cool.
Like, great, yeah, there's no coming great. That's like it's really challenging. It's like,
Are there any? We'll wrap up in a minute. Are there just practically? Are there any other sort of like use of technology you might recommend it to your patients, or that you guys have found helpful that others could try? The steps is a good useful thing. That's pretty easy.
I mean, the care everywhere thing is great, that's not for our patients,
Yeah.
but like encouraging, because like I, like just yesterday saw a lady who did like 3 different practices, it was so nice because like I was able to get her echo and all the reports like at the time of the visit, and it was so nice because, I got her 3 different places that she goes to, and it was like, so I encourage you to like sign up. Yeah, so getting people to sign up when you're at other places to get information for us to access stuff is really helpful.
Yeah, I just thought it was an interesting moment, an interesting like pushback because like a
Yeah.
lot like he kind of talked like 5 minutes
That's evil.
and just a lot of people, he was very strongly supported after
Yeah.
he made it.
this is like disconnect, right? Because you can do these
Yeah.
things about like, oh, like we're like a year away from like Watson seeing all of our patients, and we're like here, like no one here's involved. But like, like we couldn't get the like lung cancer screening GPS to like
Right.
a year for every patient, right? And so it's like, it's like simple, but somehow it's like we're all gonna be replaced in a year.
Right.
It just seems like there's this massive gap, and I feel like we just speaking the truth a lot of this is very simple.
All right, well, thanks everyone for coming. Just quickly, here's everyone again. Good job, everyone. And then again, this is sort of like the upcoming, this is the upcoming schedule for the month for Grand Rounds. Thank you, everybody.